Guys, welcome to Clinical Unfiltered. Give me your hearts, your minds, and your teeth. And today we're going to get unfiltered with just me, Dr. Sausha. No guest today. I wanted to take another deep dive, or at least give you my spiel on why 3D printing surgical guides, implant surgical guides, can be a profound office builder, career builder, and just an all-out fun way to do implant dentistry, amongst many other things. You'll hear my spiel. You'll get why I love it. Now, granted, I am coming from a super biased standpoint. I feel like the ability to print implant surgical guides propelled so much of my career, from residency out into the real world, and still to this day. I mean, I'm sitting here just preaching about printing your own surgical guides and implant surgical guides. I will tell you the story, and I think I've touched on this before, the story that starts with me printing implant surgical guides. It's the reason I wanted to learn anything about digital dentistry, digital implant dentistry. I wanted to print my own surgical guide. I thought it'd be a really cool project. So day one of residency, I was trying to, in my periodontal residency, trying to figure out how I could do this. How could I make my own implant surgical guide? And that just journey to figure it out, once I had a direct goal, and this is how you should do anything, any CE training, any new technology buying, you should find something that you want to kind of propel you forward. You want to find a goal and use all these other tools and learning and CE to get you to that goal. Surgical guide was mine. And it really, in that process, man, did I drag with me a lot of other knowledge in implant dentistry and digital dentistry and in 3D printing. Now, I kind of talked about the importance and the basics of 3D printers. And at this stage, I want to refocus on the concept of just surgical guides. Because I will tell you, circa 2010, 12, 14, 15, I mean, even today, I feel like we get a lot of lashback on using surgical guides, period. It's you can place implants without surgical guides. You don't need a surgical guide to place a dental implant. Very true. Unbelievably true. I can nail it most of the time. A lot of the time, I can probably put it exactly where I need to place it. And I will tell you, I have this conversation with everybody. And in dental school, I did this study. I was like, hey, you know what? I'm going to put it to the test. I made these little models, and then had 4 edentulous spaces on these models, and essentially had dental students try to create osteotomies, just a pilot hole osteotomy, which is a small 2 millimeter twister, your first drill, basically. And I showed them the plan of what I wanted it to look like on the cone beam, and then had individuals try to recreate that plan either by hand or with a surgical guide. And the surgical guide was based off that plan. So and then I just took a cone beam afterwards to see where did we end up. And based off that, I will tell you the range, the variation in that hole position. Granted, the hole looks like it's in the middle of where it needs to be. It looks like a good access hole pretty much. But the variation of the bottom of the drill was almost like a whole tooth away when you did it freehand, versus it was fractions to 1 or 2 millimeters on using a surgical guide. Now, there was still some play with that surgical guide because it was just a pilot hole guide. Just a small sleeve with a drill going through that sleeve. The range, I mean, we're talking your 1 to 2 millimeters being off to 8 to 10 millimeters being off. That's a major difference. And these were the same individuals creating those holes. And I see it day in and day out. I've placed lots of implants, and I know everyone out there who's placed a lot has put in implants and looked back and been like, I didn't exactly mean it to go there. If you're a good self-critical surgeon, you will find moments like that. I will tell you, with the surgical guide, I still find some moments like that, but less, a lot less. So, I will argue to the grave. You give me 100 implants freehanded versus 100 implants using a surgical guide. And I'm talking about someone who knows how to use a surgical guide. I'm not talking about someone who uses it once a year. They don't know how to use a surgical guide. I will take the 100 implants with a surgical guide any day. Any day. And when patients find out that that's even an option and it's relatively affordable, they're going to question anyone who doesn't do it with a surgical guide. I know the rebuttal. Often I'll get into that and how I communicate with my patients, but the power of a surgical guide has been studied over and over and over again. And consistently in scientific-based research, in vitro, in vivo studies, it always wins out with statistical significance that it is more accurate. And there's just more precision. Like, you're able to hit the same spot, the right spot, over and over again. And you're able, and a part of it too is you're able to kind of do a lot more pre-planning. So in the, restoratively or prosthetically driven world where you have to design the implant based off what your future tooth is going to look like, rather than putting an implant in and then making a tooth work, the ability to know where that implant goes and what kind of bone quality, what kind of extra work do you need to do to get that implant in the right place, and just the proper planning that goes along with that process, the overall outcomes are always going to be better with the surgical guided. And it doesn't have to be fully guided. It could just be partially guided, but some form of guidance. Because again, you're going to have to do a wax up digitally. You're going to have to figure out where your tooth is, then figure out, can the implant work in that position? How do we have to modify? If you have to modify, what limitations will the tooth have? You can communicate that with your patient. For example, if you know in the number 8 region that you're going to put an implant where the access hole is going to come out the incisal or the facial, and you know that because you looked at your cone beam, you put a tooth digitally in where it needs to go, and you're looking and you're saying, hey, this access hole, I can't make it in the cingulum. I can't make it palatal. Then you can have that communication with the patient before you put the implant in. Otherwise, you're going to try to make a screw retained crown, but you'll go in there and for some reason you can't. And then it's more you're reacting to the scenario rather than pre-planning. And you can show these images to either a referring doctor or to your patients or to whoever actually really cares. But most importantly to yourself. And so just going through that whole process can have such a significant impact on how well you plan. And honestly, you start to get a better understanding of what you're getting into. And I've gotten better at my free-handed implant dentistry by using surgical guides because of that planning process. And looking and staring at bone densities to know what kind of primary stability I'm going to get with my surgical guide. Because if you plan a surgical guide and then your drill is going through your planned path, you are hitting the bone densities as you planned. And you can feel the differences. For example, on a lower mandible, sometimes the cortical plate is so thick on the lingual. And you'll plan your guide, and when you're hitting your drill through the first cortical bone, then you drop into like cancellous bone, then your drill's dropping faster. Then all of a sudden it hits something and slides. It's because it's shearing off that lingual bone on the lower mandible. And then you'll feel it. And then that's why it's doing that movement. So when you take a guide off and you're doing your drills, you can anticipate those movements better because you kind of know how they impact your drill. So circling back, you can see that I'm just very passionate about the importance of it. And like I said, the science backs it up. There's no doubt about that. I'm going to try to show and share some of my slides on when I talk about surgical implant guides. And it always starts with that, just trying to sell the point that you need to have surgical guides. I'm going to show you this slide right here. I'm going to share with you this slide. And it's pretty much got like all the, like anytime anyone's ever sitting there and giving me slack for using a surgical implant guide, I try to collect all the different statements they've ever given me. I can place implants without it. I always end up tossing the guide out anyways. It doesn't always fit. It takes too long to get the guides. It's expensive. It's difficult. And part of that, I'll tell you, like all those different features all get eliminated when you're 3D printing them in-house. Like tossing it out because it doesn't fit, or you don't know why it's not fitting, or it seems to be off. By making your own guides, you kind of figure out how to troubleshoot a lot of those problems. And time becomes a different issue too with labs. And so a lot of these components get eliminated when you're 3D printing your own implant surgical guides. So I'm going to skip forward to one of the slides here that kind of starts to break down all the potential benefits. Okay, so I always like to start off with a slide that shows, and so if you want to watch, if you're listening, just purely listening, I'll try my best to try to visually describe, to describe what we're seeing visually. But essentially, it's a timeline. If you do an implant surgical guide and you're using a lab to do it, often you have to scan, and that's an intraoral scan and a cone beam, and send it off to a lab. They will do a lot of the planning for you. Either want to meet with you, which I will tell you I'm terrible about making any kinds of meetings. And then in that meeting, they'll try to determine if your plan was, if you like their plan, maybe you don't, and you got to modify it and tweak it. And that's just for the implant position. Then they'll show you the suggested guide. Sometimes if they're good, they'll show you how the scan's overlaid, like the scan of the cone beam and the intraoral scan, because I will tell you the overlay of the intraoral scan and the cone beam are super critical to the fit of the guide. So if whoever lab technician is working on this, and often they're not dentists, they are more kind of techs or software, they're people who just know how to use the software really well. If there's discrepancies between merging the two scans, they'll try their best, but they won't exactly be able to tell you the nuances of how they did it. If you're doing it yourself, if you're sitting there merging the cone beam and the intraoral scan, you will know how well they're merged, for one. And I will tell you, if they're not merging well and you have to kind of like manipulate it manually to merge those two, you better be ready to stop using the guide fully, because there is going to be some discrepancy when you use your guide. Because if your cone beam and your intraoral scan are not fit perfectly, that discrepancy will come out as the guide will fit the intraoral scan, but your plan for your drill is based off your cone beam. So if there's a discrepancy there, your drill is not going to go where you intend it to go. And if you know that, if you watch the merger of the two scans, you can make that call on how much you want to trust it. Maybe you just want to get it for a quick mark right on the top of the crest of the bone, and that's it. And then you'll go free-handed from that point on. Or it merges perfectly. Then you're feeling more confident about using it fully guided. Okay, let's say the design is great. They send you, let's say the design's not good, and for some reason you have to meet again. You're talking sometimes weeks to 2 weeks for a turnaround time. And then the guide comes to you. Maybe the guide isn't fitting, or you don't like the look of it before the actual surgery. At that point, man, if you don't, you've already paid for it. You're out money, you're out time, and now you got to do the surgery, and maybe you're relying on that guide. That can be an issue. If you're doing it all in-house, is what the timeline I'm showing on the right over here. If you can scan, plan in your own software, that means you're dragging your scans to nobody else but your own software. You design the guide yourself, so you know if you like it or not. You know if you like the plan or not. You get better at planning it. And then you print the guide. I will do a lot of these times. These guides for me get printed the morning of the procedure. I will have all the scans prior to. Often we do an implant pre-op visit. That means they've healed for about 4 months. We bring them in for a cone beam and an intraoral scan. And I talk to them, say, hey, if I have time, I'll pop in and say, hey, your bone healed great. This should be a pretty smooth procedure. And I'll talk to them a little bit about the surgical guide as well. But I'll talk to you about upselling when it comes to the cost slide. Have the assistants upload all the scans to the software. And this is delegation is a huge part of making any technology better in your office or your life better in general. But I do have the assistants do a lot of the scanning and uploading into the software. So the intraoral scan and the cone beam get scanned into the software. And they actually do a lot of the merging of the two scans as well. Because I have access to the software, I can go back and verify the merger of those two scans. If there's a discrepancy, I will then go in and manually modify it. But otherwise, if it's looking good, they even go to the process of at least putting an implant in the general location. Now with AI, it'll often suggest an AI position tooth. and also then generate an implant position that would be ideal for that tooth. Now, sometimes that implant's actually out of the bone or running into the neighboring tooth. The AI hasn't really like figured the best position of the implant yet. It's just basing the implant position based off the tooth. So if the tooth is like crooked a little bit, but that's where it fits the dentition the best, it might put the implant straight through the cingulum to give it the best restorative access, but that implant might be into a neighboring tooth. Nonetheless, I come in and often tweak the implant positioning. And the guide design often is generated automatically. It gives a suggestion depending on the software you're using. So I mainly use these days, I use Implant Studio from 3Shape. Very smooth software. Pretty much has all the implants uploaded to it already. So you're seeing your actual implant that you're going to work with in the actual software. And they give you the sleeves that are associated with it as well. So when you're designing your guide, which is often just like drawing a line around which teeth you want the guide to sit on, it'll generate a sleeve completely based off your implant that you choose. So for example, if I choose, I use a lot of Dentsply implants. Let's say I use a prime taper 3.6 millimeter diameter implant with an 11 millimeter length. It will generate that implant in there. And then based off the depth, create a sleeve at a certain height that's associated with their guided kit. So I don't have to do any of that. I just position the implant. The sleeve is where it needs to be. When I draw the line for where I want the teeth, it'll suggest what teeth it should sit on, but I can modify that. I often like to. I actually don't go the full arch with my guides. I often go I turn the corner where I can essentially have like a 2-finger rest to extra stabilize these guides. But often I'll tell you, they don't move that much if you have them sitting down on the teeth really well. At that point, once I click generate guide, it will generate a guide that has everything built in. All I have to do is push the sleeve in once I print it. But then I print it. So if at this point, all I'm really coming to do is tweaking the design of the implant, maybe tweaking the guide design, which both take a total of about 3 to 4 minutes by the time I have a file for my guide. So in theory, if I have an 8:30 a.m. surgery, I can come in at 7:30, tweak it, press print, which then initiates it to print in my printer. I often print in the surgical guide resin material. It's clear, so you can kind of see if it's sitting down on the teeth all the way. And then it prints in about 20 to 30 minutes, and washed, cured in about 5 minutes. And then the sleeve goes in. So I can often go at 7:30, do all the things I need for my guide at that point. And my staff does the actual, they take it out of the printer, wash it, and put the sleeve in. So my staff will take care of that. So as a timeline for me, plan the implant, make the guide, send it, 7:30. Now we're talking about it's now maybe getting closer to 8 o'clock. I go and consent the patient. By the time I'm sitting in the chair at 8:30, numbing the patient, the guide is right next to me in a bowl of Paradex. Or chlorhexidine or Stella Life, whatever it may be. It's ready for me to actually use in surgery. So there's no weeks on waiting. If I see a patient one day, I can technically do the surgery in the afternoon using an implant surgical guide. So the time efficiency is immense. The cost of these things, now this is an older slide, so I would say some of these costs are probably varied cents, but I always get people like, oh man, I got to invest in a printer. I got to invest in the software. I'll tell you, there's cheaper softwares or different business models when it comes to the softwares. Blue Sky Bio, essentially the software is free, but you will be paying for uploading each individual file for the guide. So the STL files for the surgical guides, you'll have to be paying for that. Printer itself, again, there's variations. There's cheaper ones on the market. There's the Amazon printers. There's the Frozen. There's the Minis. There's the Mini 4K. There's the Asigas, the Formlabs, the Sprint Ray. There's so many different printers, but I would be recommending going the route of somewhere in the Formlabs, Sprint Ray, or Shining department. They're formidable printers. They're good. They're good quality, and they're relatively easy to use. And so really to go all in, you're probably talking about $15K these days, 15 to 20K. And then you got to pay annually for the software. If you have the Implant Studio, for example, there's an annual update fee. What do they actually update? God knows. I mean, really, I always tell people, I was like, it's kind of ridiculous we pay that much for a software that just makes a small little dinky implant guide where you can play Grand Theft Auto 6 for like, $100. It's kind of ridiculous because that is a powerful software that require. I get supply and demand, obviously, but they can't upsell me on how complex the software is. It's not that complex of a software, so much so that Blue Sky Bio released theirs for free. So the cost to go in, it can be daunting, but I will tell you the ROI on the printers are probably the quickest ones I've seen when it comes to implant surgery. With that said, I mean, cone beam, obviously, way up there, but they're expensive. They are very expensive. Cost per guide. Let's say you were sending your guides out. Now, again, these guides are considering like single implant guides all the way to full arch guides. Prices have come down because they all have 3D printers and have to compete with us printing them themselves. So I'd say, anywhere from like $100 to honestly $5,000 if you're doing like a full arch stackable guide. But you'd probably be spending about $100 to $200 per guide if you had someone else make it. And then Essex trays, I mean, they can range, but I make Essex trays as well. And there's other ways to gamify your 3D printer. So from an overall standpoint, if you're charging for any of these things, like for example, my implant guides, we do charge $400 to $800 depending on the complexity of the case. We charge each patient that much money for the implant guide. And our cost to make it and time input is so negligible. I mean, we're talking less than $10. And so you're quickly making money, like an extra $400 to $800 per implant case. That can add up if you're doing 50 to 100 implants. And then Essex trays. I mean, a lot of times these patients need some form of restorative work, whether it be a temporary tooth that actually attaches to an implant or an Essex tray that floats over. Premolar cases, a lot of the times I'll make Essex trays. Again, I'm not sending it off to a lab. I'm making it in-house. And so I'll charge, $800, $1,000 for these Essex trays. And that's on top, again, of my implant cases. So I've suddenly made almost, like $1,500 extra dollars on my implant case. And I do 10 cases and I've paid off for my printer. I use it for so many other things besides that, but that's enough to start to see that there is a quick ROI that you can get on this. Plus, closing the cases. I will tell you that when I first came out, I realized that I had to utilize my knowledge of technology to win out other patients. I had to be better for some reason because I was too young to convince these patients that I was their guy. So one of the edges I did was take technology. I was like, hey, you know what? I had my own 3D printer. I was making surgical guides. And I said, I'm going to come up with a spiel that makes patients feel like they have to be using implant guides for their implants. Like if someone doesn't do it with an implant guide, what's wrong with them? So I will tell them, I was like, hey, you know what? We do a lot of pre-planning. I talk about the intraoral scan. It's like we scan, we take a cone beam, I merge the two into a software. I've got you, the patient, fully digital in a computer. So I can spend extra time planning this implant before you ever come in. I will figure out the right diameter and length and position because I will tell you, just like real estate, location. It matters where that implant. If I want to make this thing last for as long as it can possibly last, I need to get the right size and the right location. So I will do all that in a computer before you ever come in. I then have a 3D printer that'll make a jig that essentially rests on your teeth and guides my implant into place. I don't even tell them I'm drilling it into place. I say it guides it into place. And it makes the surgery much quicker and easier. I'm not having to fish around for where the implant needs to go or look, I don't have to open up the gum tissues as much. So you'll heal a little bit better, a little bit quicker, and the procedure itself will be a little bit smoother as well for you. But this is how we do it. This is and I'll make it seem like it's an upsell. You do it or you don't do implants with me. I will tell you, there's moments where it just ends up becoming a pilot hole guide, or I have to abort using the guide, but at least I use it to some extent, and I've gone through the planning process to create it. So everyone will get an implant surgical guide as a part of their treatment plan. And so when you have that kind of conversation, they're like, well, the other dentist didn't do it. And I'm like, yeah, that's why technology has improved, our medicine and dentistry. This is one of those great technologies that's actually been for the better, for the good. And I always tell patients, I was like, the implants that go in today are going to be better than the implants in the past for many different technology reasons, that we've improved the implant surfaces, the designs of the implants, but also how we place the dental implants have gotten much more sophisticated and better. And these implant surgical guides are how we've improved it by a lot. So when they say that, when they hear that, often they have a little bit more trust in your process and your expertise in how you're going to place that implant. And again, if they go to someone else and they're like not using an implant guide, they're going to have to be like, hey, why do you not need it? And they're like, oh, well, I place a lot of them. Well, I tell patients I place a lot of them. I place lots of them. Why aren't you using a surgical guide? Well, I don't need them. I'm really good. And I will tell patients, hey, look, in the process of learning how to use implant surgical guides way in the past, we have noticed that they do make the implants go in better positions because they eliminate our potential error. I've had many implants that I've placed without guides, and often had wished that some of them were in slightly better. I'm very self-critical, and these implant guides have made me be better in my self-critical era of my career. It's always better to have some kind of pre-plan in the process. And I don't always go down that much of a rabbit hole with all these patients, but the patients who want to hear it will listen and hear you out and be impressed by the technology. At the time of surgery, I will show them the surgical guide. I'll be like, hey, look, this is the one. It allows you to place the initials on the back end, so it has their initials on it. I take a lot of photos with the implant surgical guides in place, which I will tell you, photo taking, since sometimes some patients, depending on the type, what personality traits they have, will enjoy that you're taking photography, that you care for the process of taking photography, taking photos of your surgeries. The upsell there for me is I've noticed pretty critical in getting them, because if you just don't tell them, it's an added cost, and they're just going to see that the last implant they didn't have these added costs. So you can't completely scathe by it, whether it's you, your treatment plan coordinator, your office manager, whoever's communicating with the patient. They do need to kind of talk about the benefits of using an implant surgical guide and upsell the technology of it. It's not really an upsell, just speaking about it is the upsell because it is an improvement on how we do dental implant dentistry. So you need to get an STL and a DICOM. Then you go to your design software. You, in the design software, plan out your implant guide and create the physical guide itself. Then you send it to the printer, and then you post-process it. Again, at this point, I've delegated the intraoral scans. So step one, get an STL and a DICOM. Sometimes I'm not even there on the day of that visit. If I am, I like to pop in, again, reinforce the importance of the guide. They're watching all this digital tools be used in front of them. I often have my staff swing by the 3D printer and be like, oh, that's the machine that's going to make the guide for your implant. Because it's always going, it's always moving and acting. So it's got sound and lights. And so patients kind of can appreciate that when they walk by. And then the printing and processing part, again, that's done. The only time, again, is in that middle design process that I'm involved. Otherwise, the print and process part happens with the staff. But you better know how to use the technology yourself. You can't just entirely pass on all the steps without having any idea how any of it actually works. And you don't have to know the nitty gritty. You just have to know how the basics of how it works. So do be ready to be able to understand the tech yourself. This was the first ever surgical guide I ever printed. The first one I ever printed. Not the first one I used, but this was using a filament printer. And I think I'd shown you guys this in the past. This was actually the first case of using an implant surgical guide that I printed myself. It was in residency. I remember bringing it in, and I brought it in, and my professors were like, you're batshit crazy. You're not allowed to use, like, what is this toy you brought in? And I told him, I was like, hey, I had one professor that was like a cowboy, and I was like, just trust me on this. And I mean, it looked like a toy. It was blue. It was blue filament printer, because I think they just got done printing like Captain America arms in it from the occupational therapist. And so I put the sleeves in myself. This is using Blue Sky Bio at the time, so like I had to like guesstimate the size of the sleeves to make these sleeves fit, but they actually fit pretty snugly based off the measurements. And I created a hole for irrigation because I heard that it's hard to irrigate through these slides sometimes. through these guides sometimes. So I got my osteotomies done through this. And then what I did is I took cone beams after I placed these implants because I could tell my professors needed some verification of the process that I was doing. So, I mean, at the time it was like 2012, 13, 14, around that era where when I was doing these implant surgical guides, 2014, I think. And a lot of people hadn't started printing their own guides yet. So my professors wanted some verification of the process. I took a cone beam afterwards, and then I would overlay the two. So the green is the actual outline of the implant where it ended up, and the white and red is where I planned. Not completely perfect overlay, but pretty darn close. And so I'd show my professors that, and they were like gung-ho. So then in residency, I had actually like downloaded a cracked version of Blue Sky Bio. Like Blue Sky Bio, it was an accident. I don't know how it happened, but I could upload free STLs as much as I wanted, which in residency was great. So I did so many cases with them, and I learned the nuances of them. That was a beautiful part of the process. These are how my guides look like these days. But a beautiful part of that process of doing so many guides is I learned how to use them. It's like any other tool. It's like osteotomes, versa densification drills. If you never use them or you use them like once every 8 months, you're going to suck with it. Have you done anything once every 8 months and been like, I'm pretty darn good? No, you got to do it like consistently. So these surgical guides, if you're making them in-house, just by the process of going through making them, planning them, you're going to find out what errors lie in the process and how to overcome them. So, for example, some of the errors, common errors I was finding was the stitching, like the overlay of the cone beam and the intraoral scan. Was if I wasn't getting that right, I'd track back and notice. If I noticed my implant wasn't exactly where I wanted it to go, I'd track back, and indeed the overlay would have been a little bit off. Another thing is, I learned that even though the guides can kind of keep your drill mostly in place, there's still some play. So if you're doing an immediate implant, the socket is like sloped often. So your drill isn't hitting something perpendicular. It's hitting something like that's got a slight cant to it. So your drill hits it at an angle. And if it doesn't catch the bone well, the drill will slide and push and even move the guide. Sometimes if you have a guide and you push into an immediate socket, you'll feel the guide like kind of drift a little bit, or the drill slip, often facially, and start going towards the apex. For example, on a number 8, it'll like drill out the apex, even though you want it to hit the socket wall and go more palatal. Sometimes even with a guide, it'll do that. So I learned sometimes to actually create like a little drill mark roughly where I want my initial drill to hit. Not like a deep one, just a small little mark. And then it'll catch that mark and continue on in the planned position. Or another thing I learned was, I mean, some guided kits have has like a marker drill as a part of the guided kit. The Prime Taper kit has a marker drill. So it'll mark for me and then kind of guide the rest of the placement. I've realized that was a good trick to understand when you're going into these, when you're doing immediate implant cases. I'll still make a mark almost before I'm using the actual guided kit in the whole process. And different guided kits are, they function differently. Some have sleeves that you have to know your guided kit a little bit. And again, that comes with practicing and doing it over and over again. And again, if you're making them yourself, if you suddenly do a pilot hole guide and you're like, man, I really don't like this pilot hole guide, you can abort it, but at least you went through some steps with making the guide, so you're better at those steps. The more and more you do at each incremental step, the better you'll get. This is kind of my traditional, if I have tons of keratinized tissue if I'm doing my grafting right, I will have good bands of gum tissue. And if I got my guide and my guide fits well and the drill's hitting just like I know it needs to hit, these implant cases can be so painless for me and painless for the patient. And everyone's like, oh, I can do an implant in 5 minutes. So why? Again, so can I. But man, do I sleep easier knowing that these implants are in the optimal restorative position. I made an extra buck on, making the implant guide. The efficiency's up, and I can confirm accuracy over and over and again. I like to take these pictures through the actual sleeve of the guide. That's what you're looking at, of the healing abutments underneath, to kind of prove that, man, I am really close to my desired restorative position. Also, again, I feel like a lot of people will do implant guides because they have a tough case. Like, for example, they're close to the nerve, or they're close to neighboring teeth, or the ridge is narrow, whatever it may be. They're using guides for the first time on a tough case. That is the dumbest way to learn anything. That's like saying, hey, I'm going to learn to drive today, but give me like a Formula One car in like a heat of a race, or I'm a Formula One car running away from a bank, a bank robbery. That's what you're asking these guides to do when you're just using them on full arch cases, or you're just using them for narrow space cases. That's not where you learn. That's not where you learn with the stupid cones everywhere in a caged room in a giant parking lot. That's where you learn how to use these implant guides so that you're really good. And I got so consistently good that now I can push the limits. I can get, everyone's like, man, you're 2 millimeters, you're going to get 2 millimeters close to the nerve. I will touch the freaking cortical plate of that nerve at this stage because I can feel the density of the bone through my guide. And I know the guide's going to stop me out at a certain depth no matter what. So I can't even go that far down. So these guides do have, a vertical stop in depth. So I can go as close as I want. I feel very comfortable doing it. I've had the only case of paresthesia I've ever had actually nothing to do with a guide. It's once you get good at it, doing it over and over again, and you can if you're printing them yourself. You're not sweating the cost of these things. I will make multiple guides for some patients. For example, in the posterior, this case, I made a fully surgical guide, which has a whole sleeve. And sometimes I'll make just the pilot whole sleeve guides because it's easier to get a small drill to at least get a dimple in the bone. Because sometimes they can't open wide enough in the posterior to be able to get all your drills to the guide. And you can't use a fully guided guide sometimes. So I'll make two. Now, again, imagine using a lab. You're going to have to, the lab's going to charge you twice to be able to do that. But this is a case, again, I was able to place the implant pretty confidently where I needed to place it. For sinus lifts, I actually use it a lot if I'm getting close to a sinus. I will purposely plan the implant to stop short of the sinus. I'll make the implant like a short implant. Let's say it's 4 millimeters, 2 millimeters to the sinus. I'll plan the base of the implant to stop short of that sinus floor and then go the rest of the way with my Versa drills or my osteodensification drills to lift the sinus. So I got fancy with it. I started to play with it in different ways that I wouldn't have done if I was asking a lab to be able to do it. So this complicated case, which again was a sinus lift case, was able to do a tissue punch. And with that tissue punch, through that tissue punch, be able to lift the sinus with my osteodensification drills, put a custom healing abutment, put an Atlantis abutment on this sucker, which, this whole process was smooth as butter. The patient barely had any discomfort through any of this. And I think, the 5-year post-op on this implant, and it's looking better than ever. And again, super smooth part of that process. Again, I use that whole process on my sinus lifts all the time. The beauty of using the implant guides is it changed the way I practice implant dentistry. And to sit there and consistently say, I don't need them, I'm sufficient enough without them, it'll limit your ability to use them and possibly other tools. I will tell you, once you have a 3D printer and you're starting to make your own single implant or bridge 2 implant surgical guides, oh man, for bridges, it's phenomenal. You'll start to get so much comfortable in so many other aspects of implant dentistry. And I will tell you, the doors will continue to open up on what you can print as 3D printers continue to advance. So as we start to get into, making hybrids, which I'll talk about in another episode, is how we print our 3D hybrids, our temporary hybrids, provisionals for full arch cases with these guides. Those doors would have never opened up if I wouldn't have started printing my implant surgical guides. As resins get better, people are 3D printing final definitive crowns. Again, those people probably at some point were using implant surgical guides and just had the printer. Or now they've got a printer and now they can also print implant surgical guides. It just makes the most sense as one of the easiest uses for a 3D printer once you have that technology. Full arch implant guides, I will tell you at this stage, my philosophy on using a full arch implant guide is just not there. The way we make them, I make them. I will make tooth-borne full arch guides. What I'll do is, for example, if I'm doing a hybrid case, I don't always make these stackable guides. The issue with a lot of these stackable guides, and if you look at the research, that's actually where the inaccuracies come in. If there's any point where like freehand starts to like sometimes outweigh surgical guides, it's full arch therapy. It's the least accurate. You have less good landmarks sometimes. If it's a single implant guide, they probably have all their teeth. So the merging of the two scans is easier. The guide will fit better. If they've got like one or two broken teeth or periodontally involved teeth that are moving around all the time, and you scan that and take a cone beam, often there's discrepancy. So your guide will have some discrepancy. Also, there's not many good landmarks for the actual guide to sit on. You're often putting these pins in the bone to anchor it in, and the accuracy of those are variable. So they're like, oh, I'm going to put these pins in to stabilize it so it'll be accurate. Well, to put the pins in, you often have something mobile that you're drilling through. Your guide's loose to put the pins in. So when you put these anchoring pins on these full arch guides, they can be off. And I see it all the time. I have a partner that I work with, and he orders these $5,000 like chrome stackable guides, and I've seen him. I mean, half the time he will completely abort using them. And I'm like, the cost you just paid for that guide is almost twice my whole cost for the procedure itself, including implants, final prosthetics, just for a stackable guide that he aborted and didn't end up using. And I know people who teach these courses, and they often have to teach you how to troubleshoot using these full arch guides that you spend a decent penny on. And the issue is, again, the initial accuracy is going to be off. And if every other component of a stackable guide is based off that initial accuracy, you have a higher chance of just having more and more errors in the process. Don't get me wrong. I mean, if you're completely in the lost, or again, it's one of those tools. If you use it enough, you will get good at using it. It's just got a higher entry fee to start using those. So it might not be the most efficient thing for all the offices out there, unless you're running through these cases over and over again and getting, charging patients a good penny. It's hard to justify using those kind of guides to do those kind of cases. You should be comfortable enough really to do it without them. And that's the thing. I'm using my implant guides, but I'm comfortable enough to not use them. So having them is just an extra bonus for the patient and me. But not for full arch guides. If you go in there depending on it, you're more likely to run into issues. So I don't know if that's the best place to start. I don't know if a tight space between 8 and number 6 is the best place to start. It's that wide number 19 with miles of bone. That's where you start, or a premolar. And then you work your way to guided, to immediate implant cases. The actual cases, like how to use them in a case. I think one of the best ways is for us to actually go through cases on doing them. So as a part of my implant surgical, you heard me kind of cry about why they're so important. And I think the best way to start getting into them and use them is, like I said, making your own implant guides. Make them for individual implants or bridges or 2 implants. Get them lined up well and go through the prosthetic planning. But full arches, like take home, like maybe not start there. And if you are, make them tooth-borne. Or even better, make them bone-borne. I'll do that for my edentulous cases. I'll make them fit on the bone themselves. But I'm going to go through and show you some cases on using implant surgical guides as a follow-up to this episode. Thank you guys for getting unfiltered with me. Again, click like, comment, ask us what else you want to learn about or any kind of specific cases on using implant surgical guides you guys have. Kick it back. Maybe I'll dig deep to see if I have a case like that and share these cases. So when I do go on and show you these cases, I will be posting the videos of these cases or slides of these cases as I talk about them in the future. Again, thank you guys so much. And until next time,